Howdy YouTube family, it's Bolt CRNA coming to you again with another day's topic. Today we're talking about care plans. I know all of you previous nurses who were in nursing school, things like that, you know about care plans. Care plans stink. They were the bane of your existence back then, and now they're back again. Dum dum dum. Sadly, yes, in CRNA school we do what's considered a care plan. It's a little bit different though. So I'm going to talk to you guys a little bit what that is like today. Now, first of all, let me explain. It's different from care plans in nursing school. Care plans in CRNA school is a very different idea. The concepts are different. Your focus is going to be different because you're a provider now. So you're not learning about, nursing diagnoses like risk for fall or risk for impaired skin integrity, things like that. But the objective of making your brain think about a patient in a full spectrum of ideas and kind of bending your brain to think about patients in a new way is the similar idea of what care plans was in nursing school, where, the whole point of you doing that back then in nursing school, whether you may argue that it was effective or not, the point is that it makes you think about different things that could be going on with that patient and what you should be focusing on clinically. Like if they were a risk for nutrition impairment or like fall risks, things like that. So they wanted you to focus on multiple pieces of this puzzle as a nurse so that you kind of could expand your brain and get into that process of thinking about your patients. When you walk in each morning and you look at them, you can start listing, okay, I'm concerned today for my shift about these 6 things or my top things that I really think are going to be an issue for this patient that I should work on. Similar idea in CRNA school. You're going in for that day's case and you're looking at this particular case you're going to be doing and you're identifying what should I be focusing on for this case, what should I do for this case. Then you write out what you did and then you assess the outcome and result of what you did and figure out, was it the right thing to do? So let me break it down a little bit more for you. So we had to, in second year of CRNA school, we started clinicals, and we had to do, for the first 7 months, we had to do 10 care plans each month. So that's about 70 or 80 total we ended up having to do. And each of these cases were supposed to be something slightly different. Like, they didn't want you to pick the same type of patient every time. Like, they didn't want you to pick a laparoscopic cholecystectomy 10 times for the month, because you're not learning that much from that particular one type of case. Because really where you grow clinically is by different variations of different cases and seeing different types of surgical situations happen, and a lot of that happens when you change up the case types. So they would encourage you to do different types of cases. So you would pick the case the night before surgery and you would identify like the basic patient's information, not like their name and things that were like private data, but information that was relevant, like 74-year-old female. You would write down their medical history. They've got a history of CHF. They've had an MI in the past. They've had, type 2 diabetes. So you figure out like the basic idea of who this patient is going to be, like what they're going to look like clinically when you walk in and see them in the morning. Then based off that medical history, you're going to start looking up lab data. You're going to start looking up chest x-rays, echocardiograms if they have it. All of this stuff, you're going to identify like what do you need to be looking for. So they've had an MI before. How long ago was the MI? Did they have stents placed? What kind of stents did they have placed? Drug-eluting, bare metal stents? How long do you have to wait after those stents were placed before you are allowed to have surgery? If they have reported about their activity level anytime recently, if they have data on that, you can identify, are they active physically? Like, do they exercise? Are they bedbound? If they're bedbound, then you definitely would want to investigate what's their ejection fraction. Have they had an echocardiogram done? Is their heart in good health? Like, obviously it's not in great health, but like, how bad is it? If you find out the heart attack was 6 years ago and the patient reports on a recent physical that they jog 5 miles 3 times a week and has no problems, then you can imagine they're in pretty good shape. Like, they're not someone that you would be concerned about very much. And you may say, hey, I want an echo anyway. That's your choice. I mean, there are some clinicians that say if you've had an MI, I want echo. That's something that you kind of have to decide. But clinically, I would say that's probably not very relevant. If we're having a cabbage tomorrow, then yeah, probably a good idea just to do an echo, have a baseline. We want to have that kind of baseline information. If we're doing a colonoscopy, a screening colonoscopy because they turned 50, no, I probably don't want an echocardiogram. That's excessive in my clinical opinion. So essentially, that's what your care plan is doing. It's training you to assess what's going on with this patient, figure out lab data in the history of that data and where it's trending and stuff, and what you need to know before tomorrow's case. If they need that echocardiogram, you need to be ordering it the day before or something like that so that you know that they can have something done before the surgery tomorrow. So say you've identified all their medical history now, you've identified that their lab data is okay, and now you're going to make a plan up for what your anesthetic plan of action is going to be for the following day. Are you going to use ketamine? Are you going to use paralytic? Does this type of surgery need paralytic? If you're going to use paralytic, how much are you going to use? What type of paralytic are you choosing to use, and why are you using that type? All of these things go into your ideas of like exactly what your anesthetic plan is going to be for tomorrow. And not just drug, you'll also make a plan up for like what kind of devices are you going to use. Will this patient need an OG tube? Will you place an OG tube after they go to sleep the next day? Are you going to use a Miller blade, or are you going to use a Mac blade? Are they going to be do you anticipate them being a difficult intubation if they have ankylosing spondylitis? Are you going to plan for an awake fiber optic intubation then? What utensils and devices do you need before you do that? What should you look up to prepare yourself for that type of intubation technique the next day? All of these things are very relevant and valid points that you focus on for your care plan in CRNA school. So now that you've written down all the meds that you're going to use, the devices you're going to use, and you have a good idea of exactly how to approach the patient the next day, you're going to go in the morning, you're going to share your care plan with your preceptor. They're going to approve of the choices that you've made, and they're going to say, yes, I want to use rocuronium, and no, I don't want to use ketamine, and this is why. And they'll usually give you justifications for the reasonings behind why they don't agree with your plan. Or maybe they do agree with your plan, and it's just slightly different from the meds they prefer to use, and they just tell you, I don't prefer to use that drug and I'm not as comfortable with that one, so I'm going to choose to use this one instead. Sometimes that just happens. It doesn't mean it was a bad plan. It just means it's not what they were choosing to use that day. Then you will actually go through with the case. You're going to try and do the plan that you laid out beforehand, and hopefully everything goes as according to the plan and everything goes smooth. But a lot of times in anesthesia, things change. Vent settings will get changed. The types of devices that you may end up using will get changed. Things happen in surgery that are not as planned. So a lot of times plans change a little bit. You use more of the drug than you expected you were going to have to use because the patient's physiology required more. All of these things are very valid points in anesthesia. And so what the care plan does is it identifies for you that you've made up the plan, which is a good idea. The plan will probably change a little bit. And then after the surgery's over, you'll take the patient to the recovery room. You'll identify, are they in pain? Are they nauseated? Are they vomiting? Did you bust their lip when you intubated them? Like what's going on with the patient post-op? Are they happy? Are they sitting up in bed and alert and saying, I'm pain-free and I can't believe we've already had surgery. I barely feel like anything hurts at all, and they're already ready to be discharged home. If that's the situation, you can say, wow, this was a really smooth anesthetic and the choices we made worked out really well. Versus, like I said, if the patient's vomiting, if there's other complications, you can identify, what should I have given a third antiemetic? What should I have done differently? So you critically assess your anesthetic plan based off the outcome in PACU, what you can tell how the patient did. So essentially you write down what the patient response is in PACU, and you write down what you think about the anesthetic plan. Did you think the plan went well? Would you have changed something in your plan for the future? And oftentimes the goal of the care plan is for you to assess critically what you did. And even if it was a good anesthetic plan, they're probably looking for you to give them some critical feedback about yourself so that you could say, It went good, but honestly, I would have probably rather just used the propofol and not use the ketamine because the patient was a little bit dissociative still in PACU and a little bit tricky for the PACU nurses to handle, and maybe it wasn't that great of a choice. Maybe it would have made more sense to not use the ketamine in this particular case. Maybe the patient was emotional and crying and, seemed very odd, like maybe I should have given a little more Versed with the ketamine, whatever that may be. They're looking for you to critically assess yourself. And to be honest, even now as a CRNA, I do that pretty much after every case. And pretty much everyone in anesthesia does that. You check on your patient in PACU, you see how they went. There are times where you'll see your patient, you'll be like, I maybe would have done this a little bit differently if, in retrospect, looking back. So there's always that ability to learn and to grow and to continue to shape your anesthetic and your critical, plans and stuff. As you continue on in anesthesia, you'll always do that. So they're just getting you in the mindset of doing that in anesthesia school. So yes, care plans are still there. They are better than they were in nursing school. Still kind of annoying because they are a lot of paperwork. It's a lot of writing. After you've done 50 or 60 of them, sometimes you get a little bit annoyed that you're writing out all this information when you already know that you're going to be assessing your patient critically. Like you don't, at least myself, I didn't need to physically write it all out in intricate detail to prove to someone else that I was doing this process, because I knew I was doing it and I knew that I was going to continue doing it because I wanted to be the best clinician I could be. And so I didn't necessarily need to write it out in long form for someone to read because it was time consuming. And as much as you're studying and as much as you're trying to get done for CRNA school, especially on top of the research and your DMP projects and stuff, it just kind of is time consuming. So I was grateful after about 7 months or 8 months when they said, okay, you guys have done enough. We've seen that you guys kind of get the idea of how to do this, so we're not going to keep making you do this forever. Now that did change when we started third year and we started specialty rotations, because for your cardiac rotation where you're doing open heart surgeries and stuff, and for your obstetric rotations where you're doing mothers who are giving birth and in labor, and you're doing C-sections and lots of epidurals and things. In the pediatric rotation, those types of cases are very different from your typical surgery cases. So we did have to do, it was 10 or 15 care plans each for each of those rotations to kind of show that we were thinking through this process differently because it's a different type of anesthesia. And that's pretty necessary too. So overall, it wasn't that bad, much better than care plans in nursing school. Well, all right, guys, what do you think about care plans in CRNA school? Does it sound just as bad as care plans were in nursing school? Did you actually like doing care plans? Were you one of those odd people in nursing school who had a 15-page care plan and had all these pictures cut out and just went way over the top and really impressed your clinical preceptors who were, looking over all of our care plans? There was always that one who had a 100 on their care plan, and the clinical preceptor raved about how impressive it was, about how they wrote for risk for falls in such intricate detail with 15 sources cited. So if you're one of those people, I love you still, but yeah, you're annoying. So anyway, leave your comments down below what you guys think about your care plans and if you're looking forward to them in CRNA school, and that's Bolt Out.